Hi, I'm going to present pharmacotherapy for chronic pain. This talk was originally presented by pharmacist Penny Miller for the University of British Columbia Family Practice Department, and she did this for the Pain Practice Support Program. So I'm going to try to draw from her insights in that talk. So we're hoping that you're going to draw from this talk just some basic principles around the medications that have the best evidence to date. So it's not going to be a comprehensive talk about every medication, but it is going to be highlighting the ones that are commonly used today. And then also to highlight the problems with the use of those medications in certain types of pain syndromes that have been studied, and finally any controversies that have been raised in the literature so far. In these medications, I won't be addressing the opioids because that will be addressed in another talk. Well, having said that though, the principles of using medications in pain management was drawn from the original applications in cancer pain therapy. And this is, as you know, the World Health Organization ladder for using opioids. But you can see in the far right-hand corner, they've kind of appended the adjunctive therapies that are non-opioids. So again, the principles of go low, go slow, use the medications which has the least amount of side effects, is still holds true for even the adjuvant medications that are not traditionally opioids. So what is an adjuvant medication? It really is any medication that wasn't primarily indicated for pain management, such as you see in these four groups: tricyclic antidepressants, selective serotonin reuptake inhibitors, the anticonvulsants, and some topical agents. There are other groups such as the cannabinoids and local anesthetics and other types of medications that won't be covered in this talk today, but essentially they have derived pain management properties from the observations in its regular use for its normal indication. So the following few slides are going to be focused on the anticonvulsant groups, or otherwise known as neuromodulators, especially with neuropathic pain. Before I launch into the next medications, just wanted to highlight the principles that influence how we choose those medications. So they include the type of pain, the intensity, if a patient can be compliant with the dosing schedule, if they even have access to it, because financial circumstances can limit the options. But in the literature, they use the principles of NNT, numbers needed to treat, and NNH, which is numbers needed to cause harm. So in these next few slides, I'm going to be talking about common anticonvulsants. These two here are the alpha-2 delta calcium channel blockers, gabapentin, and pregabalin. Again, we just wanted to highlight that the studies have been focused in certain types of pain syndromes. They haven't been applied to all neuropathic pain syndromes. But as we have found in our practice, practically, we have started to apply them in different types of pain syndromes that may have a neuropathic component. In particular, though, I wanted to highlight the studies data with gabapentin in the use of postherpetic neuralgia and painful diabetic neuropathy. And so you can see here the numbers needed to treat are moderate, so somewhere between 2 to 5 in most pain syndromes. It gives you confidence of its efficacy in its use. In general, gabapentin is used with an average dose of 1,200 milligrams, could range up to 3,600 milligrams in a total daily dose. And usually it's divided TID. With pregabalin, it's a brother of gabapentin, and for some of those who don't tolerate gabapentin, sometimes they can tolerate pregabalin better. Also, there's a cost factor relation to these two medications and how you choose to use them. Gabapentin, onset of pain relief is a little slower than pregabalin, so pregabalin may be one that you trial first with ones that you need to see a faster effect. But in particular, it was studied in postherpetic neuralgia, and you can see that it was more effective as compared to gabapentin. So, as you can see on the far right screen, common dosages are about 300 milligrams total daily dose, but as high as 600 milligrams divided in twice daily dosing is often used. As you can see in this slide, I'm highlighting two of the older anticonvulsants, carbamazepine and lamotrigine. In here, carbamazepine has been actually trialed in a number of neuropathic pain syndromes, in particular trigeminal neuralgia, postherpetic neuralgia, and diabetic neuropathy. In this slide, we're just highlighting the fact that a lot of the trials, especially when it was done in earlier years, they did not go beyond 4 weeks of observation period. So the actual bulk of the studies don't seem to have adequate quality to make some interpretations from there. But practically speaking, they are commonly used for a lot of the oral facial pain, neuropathic pain syndromes. In this slide, I'm just talking about more details on how to titrate up the gabapentin. So depending on renal function and liver function, but in particular renal function, you may actually want to start at a much lower dose. And those on dialysis is a totally different story altogether. You would really not need to titrate up because this is related to the dialysis period. But that's not in scope for this talk today. Most people, depending on age, would start at about 300 milligrams. A person who's older than 65 may be better tolerating this medication at the dose of 100 milligrams. And often the titration period is every 3 to 7 days, depending on how they're tolerating the side effects. Unfortunately, as the doses go up, the actual amount available goes down. So surprisingly, at the average effective dose, around 1,200 to 1,600 milligrams, less than 1/3 of the dose that they're taking in is actually available for use. In general, pain relief can be seen within the first 2 to 3 weeks after you've started the medication, and that pain relief effect is really based on the actual therapeutic dose. So if they're titrating that up very slowly, it will take longer. This slide highlights how to titrate up with pregabalin. It's the same principles, the smallest doses that are available at 25 milligrams. I often start either a 50 or 75 milligram capsule and increase that every 3 to 7 days like it is with gabapentin. And the actual pain relief period is a lot faster. So some people can in fact titrate that even faster if they're tolerating without side effects. So as you can see by this slide, there's a number of side effects associated with all the drugs, but in particular with the anticonvulsants. Most patients complain about some level of the cognitive dysfunction, such as memory problems, slowed thinking, altered speech, dry mouth, fatigue. The problematic side effects could also include this peripheral edema, which leads to weight gain, and blurred vision. These are not to be missed and need to be switched up quite quickly if those kinds of problems occur, especially in the first 2 or 3 weeks. In the next few slides, I want to talk about the analgesic properties of typical antidepressants. This slide is going to highlight the 4 common antidepressants that are indicated or commonly used with chronic pain patients. For amitriptyline, one of our oldest tricyclic antidepressants, it's been most effectively used in painful diabetic neuropathy, fibromyalgia, and postherpetic neuralgia. Because it's one of our oldest medications, it's been studied the most, so there's a lot more data around it, whereas if you take a look at duloxetine, it's come onto the market only in the last few years and only has a very directed indication towards diabetic neuropathy and low back pain. The other medications here, venlafaxine, and the general group of tricyclic antidepressants such as nortriptyline, sertraline, and diazepamine are lumped in together in that third line. So without reiterating the far sidebar, there's quite a variation in terms of how to prescribe the medications, and I'm going to go into that in detail in the next few slides. In this slide, I'm going to highlight and focus the use of tricyclic antidepressants. This is a pretty broad group. The oldest one is amitriptyline. The newer ones are meant to have fewer side effects. But in general, they have a real mix of side effects because they sit on a number of receptors. The cholinergic receptors, norepinephrine receptors, even some of the dopamine receptors. And so you'll see the effects such as dry mouth being a very common problem and complaint. blurred vision, urinary retention, tachycardia. In particular, with patients who are using multiple medications, we have to watch out for. And both as a good effect, but as a bad side effect, is sedative properties of all the tricyclic antidepressants. Amitriptyline is the most sedative out of all of them that I found so far. The strong precautions to be taken here is if someone has benign prostatic hypertrophy, glaucoma, any arrhythmia problems, which may in fact be exaggerated by the use of the tricyclic antidepressants. So a screening ECG is a good standard practice to start with. And doses to be starting low at 10 milligrams is very reasonable, usually a couple of hours before HS to see its daytime effects the next day. So how do we decide if we're going to continue using the antidepressants, in particular the tricyclic antidepressants? We want to see a change in mood, change in pain, particularly change in function, but sometimes only a change in sleep is the major benefit. But that in itself is great because it changes ability to function and coping. If we're going to taper off any medications, the tricyclic antidepressants in particular need to be tapered and not discontinued abruptly because it can cause some rebound effect. Because tricyclic antidepressants have so many side effects, we just have to bear some of these synergistic problems in mind. Tricyclic antidepressants can change the way liver function at the cytochrome 2D6 works, so that medications such as codeine doesn't get metabolized into morphine and becomes ineffective. When you mix tricyclic antidepressants with other CNS depressants such as alcohol, benzodiazepines, that can really exaggerate sedation and fatigue. And to bear in mind that any problems with the bowel, especially with using opioids, or that the bowel function is already slow, or urinary retention, tricyclic antidepressants are really going to exaggerate those problems. And then finally, we just have to be careful with the concurrent use of SNRIs, SSRIs, and tramadol because of the potential for serotonin syndrome. This is rare, but when it does occur, it's quite severe. This slide here is highlighting two of the newer SNRIs that are out on the market. Duloxetine in particular has been indicated for back pain, hip, and knee, and has been trialed in fibromyalgia and diabetic neuropathy. Duloxetine usually is started at 15 milligrams or 30 milligrams single daily dose, and within about a week or 2 weeks, if they don't have any side effects or problems, you can increase that to 60 milligrams if the effect isn't as strong. Because it's an antidepressant, all of these have to be titrated up slowly with an observed period of effect over at least 6 to 8 weeks before we give up on that medication in general. But if the side effects are really strong, then we have to wean down slowly. Highest doses that I've seen used for pain management is 120 milligrams once daily dose. With venlafaxine, we usually start at about 37.5 milligrams. And again, the slow titration done every week to 2 weeks can go up to a maximum dose of 225 milligrams. Others have used higher, but that is really the recommended highest dose for pain management. We don't have enough time to highlight all the different studies out there that are looking at combination therapy, not just between two drugs, but within multiple drugs and even non-medication strategies. Unfortunately, the studies are really hard to do, and it's hard to tease out which medication is doing what effect. However, there are some studies that highlight by using a combination of two different medications that are sitting at different receptors that there is an enhanced improvement in pain relief. For example, here, two studies using 386 patients in total showed some modest benefits in the combination of an opioid and with gabapentin. Now again, there's a lot of adverse effects because of some of those overlapping side effects of both of those medications. I guess in summary that we have to just use each one of these medications with caution. Trying to keep it simple with one medication is the most ideal, and if we're adding another therapy, it is to start very low doses with longer observation periods so that we can see if there is in fact benefit from adding a second one without the cost and the risk of the side effects from other medications combined. In the next couple of slides, I want to touch on the use of topical agents and creams. So what is the evidence for topical agents? There are even fewer studies with the use of creams in terms of pain management. Capsaicin and anti-inflammatories like Voltaren have been more commonly studied. They are showing some of this evidence as highlighted on this slide. In capsaicin gel in application for the topical allodynic syndromes like postherpetic neuralgia, there seems to be some application that's helpful, but it's very difficult for many patients to tolerate at times unless you warn them and titrate up the dosage from the lowest of 0.025% to the highest acceptable dose of 0.075%. In syndromes such as osteoarthritis, this is also being trialed, even though initially it's never been thought of as a neuropathic pain syndrome. But there's more and more evidence that osteoarthritis has that component. In this slide, we highlight anti-inflammatories like Voltaren. It's been traditionally used for arthritis type of management. The NNT here is very good, but practically speaking, it does not have the effect for deeper pain syndromes because penetration of the creams are limited. Any benefit is coming from the systemic absorption of these creams. So in summary, I just used the slides previously to highlight the treatment principles because there's still many medications we could not cover in this slideshow today. In general, we are trying to maximize the non-medication measures where possible, and there's numerous available resources now in BC. We want to ask, is that medication essential to change their function? Sometimes only through a trial can a patient be convinced, and also that we can understand the effect and possibility of that group of medications. And then the question is, are the treatment goals clear? Because if they aren't clear, even starting a medication doesn't give us personal guide as to when we'll stop, taper, rotate, or discontinue altogether. And then finally is that we just have to be aware that the responses, despite the number of studies that I presented here today and the kind of NNT numbers, everyone's response is quite variable. So the other treatment principles is just to bear in mind that when we're introducing a new drug, we just really don't want to make their pain syndrome worse. And it's not necessarily the pain that we're making worse, but it may be their function, such as sleep or cognitive function, their energy levels. And so we're bearing in mind the previous treatments and concurrent treatments that they're taking. The second thing is if the medication is well tolerated, we are hoping for a shift in their pain by at least 20 to 30% to bear in mind the dosage that we're on with that medication. If there is some pain relief and there is no change in function, one has to wonder if we're going to continue with using that medication, because with every medication there's still side effects. So what we're hoping to emphasize with our patients is that some form of their function is changing, not just that their perceived level of pain has changed. And finally, if we are not seeing a huge change in their function or their pain relief, or it's minimal pain relief, this is where we might start to think about adding a second agent. Again, bearing in mind that those additive side effects can be a problem with their overall pain-related disabilities. So this final slide is just highlighting more treatment principles to keep the use of these adjunctive medications safe. So just like it is with opioid management, the 6 A's of pain management is really key. Are these medications changing their pain, their function, their mood, and are they used appropriately? And if they are, it makes sense to actually include them in their regimen. So ultimately, we want to always review to make sure that we are seeing the effect over time. Often these medications can reach a plateau in the way they have effect, or that there may be better ways of managing their pain that they've now discovered that they don't have to rely on medication. So frequent and regular review makes sense. And that regularity is depending on the patient and how they're using it. It's important to design a future plan to taper off medications once you've made that review. And tapering is key, in fact, with all of the pain medications. Abrupt stopping actually causes quite a bit of withdrawal for opioid type medications, but for adjuvant medications there's often a rebound effect. And when that happens, this is very distressing and can also have make a patient lose confidence in the way the medications will help their pain. So in summary, to simplify our approach with using medications with pain management, once we've completed a history and the physical exam and try to differentiate the different types of pain, then the groups of medications become more obvious in terms of which ones that we can use first. And obviously we want to set some realistic goals up front. It doesn't matter that they're not opioid medications, even with these adjuvant ones. We want to have some goal in mind so that we can review and make use of that time to either look at other options or to taper and put together that plan for them. And to set those expectations up front so that they don't constantly feel that only the medication is their only tool. And then finally, we want to be flexible in our periodic review, because even if someone is on a stable medication, if they've gained a different type of strategy in managing their pain or dealing with their reduced function from before, whether mood, sleep, at work, then if we can taper off medications, we should try. When the medications get more complex, obviously the ideal is to have some backup with pain specialists involved, either virtually co-located or a face-to-face, especially referral. In accessing our resources, the trusting relationship and open discussion around the use and appropriate use to keep these medications safe is the key to effective pain management. Thank you for your attention. I hope this was helpful.